Hey all, welcome back to the Real Life Pharmacology podcast. I am your host, pharmacist Eric Christensen. Thank you so much for listening today. Today I'm going to tackle drugs 26 through 30 in the top 200 drug list. As a good reminder, go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher if you're out in practice. Definitely a no-brainer to get. Simply an email is all that it will cost you to get that. We also get you updates when we got new podcasts available as well as other content. So definitely don't hesitate to go subscribe by email at reallifepharmacology.com. All right, let's get into the 5 drugs that we are covering today. Number 26 is Fluticasone. Brand name of this medication is Flonase, and this is definitely a commonly used medication for allergic rhinitis. So again, runny nose, eyes, those type of thing. Obviously, it's going to probably have most benefit with the runny nose associated with allergy symptoms. It's classified as a nasal corticosteroid, and ultimately, by its mechanism, it's going to reduce inflammation, reduce irritation, and obviously help some of those symptoms associated with allergies. Now, a couple things to note with this medication. It's usually pretty well tolerated in general. One important patient education point I want to make is that it does take a few days to kind of work. So I have had patients basically come back and say, or they take it, and then they call, hour or 2 hours later, and they say, hey, it didn't help at all. And in a majority of cases, that's probably common, where it definitely takes maybe up to a few days to really start to get to that maximal effect and reduce some of the symptoms of allergic rhinitis there. So again, very, very important patient education point there to kind of help patients recognize that it's going to take a little bit for this medication to work. Side effect profile, systemic absorption of this corticosteroid is going to be low, so it's really not something I worry about to a great deal there. More so, the adverse effects are going to be local. So you've got nasal irritation, nosebleeds have definitely been reported. Some of the patients will feel a bad taste in their mouth, with the administration of that spray into the nose, and then, potentially dripping down into the mouth and that type of thing. So kind of more irritating type symptoms in general versus any type of severe adverse effects. From a drug interaction standpoint, we really don't have much systemic absorption. So in general, I don't get too frazzled about any kind of minor drug interactions or anything like that. All right, number 27, we've got Allopurinol. Brand name of this medication is Xyloprim. And this medication reduces uric acid, which ultimately helps prevent gout flares. Okay? And one important thing I think to remember is that allopurinol is for prevention. It actually doesn't help with an active gout flare because it takes time, obviously, to block the production of uric acid, which is how this medication works. So, again, really, really important that this is not a treatment for an acute gout flare and relieving, the pain associated with that. For acute gout flares, we typically use NSAIDs for that pain and inflammation, or possibly corticosteroids there as well. Those are two of the most common medications used for a gout flare and some of the pain associated with that. Mechanistically, it's a xanthine oxidase inhibitor, which is an important enzyme in the production of uric acid. So by blocking by blocking xanthine oxidase, we essentially block the production of uric acid. Adverse effect profile, typically pretty well tolerated. One thing I do look out for in practice is skin reactions. I remember one case scenario where a patient, I believe, was on about 300 milligrams a day, and they actually had a situation where renal function got worse over time. And allopurinol is dose adjusted per renal function, so that's something to pay attention to. So those dose adjustments weren't made as the renal function got worse over time, and the accumulation of that drug, concentrations getting higher, likely led to a situation where we ran into a skin reaction. And it can be a very, very severe skin reaction. Again, very, very rare. It doesn't happen incredibly often. But in patients who have genetic variations, they can be at higher risk. And that genetic variation is HLA-B 5801. For maybe more advanced folks, med students, BA students, pharmacy students, that's definitely something I've seen show up on board exams, pharmacology exams, with that genetic variation and then being at risk for skin reactions, or at greater risk for skin reactions from the medication allopurinol. So good little nugget to remember there. And then I alluded already to those renal dose adjustments. Definitely pay attention to that in making sure that we've got the appropriate dose based upon the patient's renal function. As always, I have done allopurinol and many, many other medications in the past. Over 300 episodes on specific drugs where I go into a lot more detail, on drug interactions, mechanism of actions, all that sort of stuff. This is just kind of a little bit more of a broad general overview of things I commonly see. So again, go check all those out, reallifepharmacology.com. I've got them categorized by kind of disease state or general categories there, so you can look at that, as well as simply type in the drug and see if I've done a podcast on that. So again, you can find all that at reallifepharmacology.com. The episodes are also found on many of your podcast platforms as well, such as iTunes and Spotify. All right, next drug, number 28, we've got Alendronate. Brand name is Fosamax. This is classified as a bisphosphonate medication used primarily for osteoporosis. Remember the ending with this medication, Alendronate. We've got risedronate, ibandronate. So again, kind of that ending can kind of tip you off to help recognize that this is probably a bisphosphonate medication used typically for the management of osteoporosis. Mechanistically, it inhibits osteoclasts. If you remember osteoclasts and osteoblasts, they are important in bone turnover. Osteoclasts break down bone. Osteoblasts build bone. Okay, so if you remember blasts build BB, that's probably the easiest way to remember that. And osteoclasts break down bone. So bisphosphonate medications inhibit osteoclasts. So they basically block the breakdown of bone, which, for homeostasis, we're looking at managing those calcium levels between the bloodstream and between the bone. The osteoclasts break down bone and can, kind of help normalize calcium levels. So by inhibiting those osteoclasts, we can help keep that calcium in the bone and obviously help with brittle bones in a situation like osteoporosis. All right, Alendronate has really, really specific administration. It's an oral medication, and it needs to be taken with plain water, full glass of water ideally. And we do this to prevent esophageal ulceration and esophagitis. Okay, so that's why we give it with a full glass of water. We want to make sure that pill gets down and through and into the gut, and we've got adequate fluid around that so it doesn't get stuck and cause that irritation and potentially ulceration. In addition to that, it is not recommended to give with any food or other medications. What can happen to Alendronate? It can definitely be bound up by other food and medications, and then it doesn't get adequately absorbed, and obviously you don't get the potential benefits there. Another important administration pearl with this medication is to remain upright for at least 30 minutes. And again, if you could imagine taking a pill and then laying down right away, that pill could much more easily get stuck in the esophagus, and it's going to cause that irritation and potential esophagitis and ulceration risk. Other adverse effects, risks associated, there's atypical femur fractures that's been reported with bisphosphonates. Another rare one is osteonecrosis of the jaw. Patients there's a bunch of risk factors for osteonecrosis of the jaw, but probably the one you hear promoted the most is somebody having a recent dental procedure or surgery. Patients may be at a little bit higher risk there for osteonecrosis. And basically that's osteonecrosis of the jaw, pain, swelling, bone can actually be exposed. You can actually lose teeth. Basically that's kind of making the jawline, jawbone brittle and some of the teeth as well. So definitely a really, really challenging thing, but a really, really rare thing that I've really only seen, I think, once or twice in practice, being a pharmacist for well over 10 years now. So again, very, very rare, but obviously can be pretty serious there as well. All right, moving on, we've got Famotidine. Brand name is Pepcid. This is an H2 blocker. H stands for histamine, so histamine 2 blocker. And in the gut, parietal cells blocking histamine or the histamine 2 receptors, we can reduce stomach acid production. So as you can imagine, famotidine is used for heartburn, GERD, potentially GI ulcers if PPIs are not appropriate for some reason. So really these famotidine and PPIs, those are really two of the most commonly used medications for GERD and heartburn type symptoms. The advantage probably of famotidine, it tends to work a little bit quicker than PPIs. The disadvantage with famotidine, it's probably not quite as potent at reducing that stomach acid as PPIs are. Rare cases, you may see some issues with central nervous system adverse effects like confusion and that type of thing. Again, not something I've really seen in practice much at all, but there are some risk factors for that. So older age and worse renal function, they may be a little bit more at risk for some of those CNS adverse effects. Again, not something I'm usually crazy worried about in somebody on lower dosages, like 20 milligrams, for example. But if you do have a patient maybe on higher dosages, poor renal function, older patient, maybe that is something to pay a little bit closer attention to there. And then last on the adverse effect profile, if famotidine is used on a chronic basis, we can reduce the absorption of B12 over time. So again, if you're using it longer term basis, those B12 levels do have the potential of falling over time. And that is something to kind of keep tabs on there. All right, let's take a quick break from our sponsor. Go check out meded101.com/store if you're looking for board exam study materials like NAPLEX, ambulatory care, BCPS, BCGP, many others. Meded101.com/store. We've got all the links there. I've literally helped thousands of pharmacists pass their board exams. If you're a nurse practitioner, pharmacy technician, med student, PA student, other healthcare professional, we've got tons of different books and resources. Case studies, drug interactions, primary care information on drug interactions, lots of different resources, fun resources as well. Crossword puzzle books on pharmacology, for example. Great little, gifts, study guides for those maybe going through board exams or various things. So go check out all those resources. Help to support the sponsor, meded101.com/store. All right, and last but not least, we've got Cefdinir. Brand name of this medication is Omnicef. This is a third-generation cephalosporin, And as you could maybe tell by the name, if you ever see Ceph, CEF, or CEPH within a drug's name, it's probably a good guess that it is a cephalosporin antibiotic used to treat infection. Now, we've got multiple different generations of cephalosporins, and they treat kind of a variety of infections and a variety of different usages, so that gets to be a little bit more challenging and into the weeds. But on Cefdinir here specifically, I alluded to it being a third-generation cephalosporin. All cephalosporins block bacterial cell wall synthesis. Where I've seen Cefdinir used most frequently is probably in pediatrics as an alternative to penicillin antibiotics like amoxicillin, for example. So common usages, you might see otitis media, strep throat. So again, some of those more common infection in pediatric patients, Cefdinir can be used as a potential alternative if patients can't take amoxicillin, for example. Now, why is it used in pediatrics? Well, we've got a suspension formulation. So we've got a liquid formulation of Cefdinir, and obviously that can help us with the administration in young pediatric patients. Adverse effect profile, as you could expect, and as is common with most antibiotics, they cause some GI upset, so nausea, vomiting, diarrhea. I would say I've probably seen diarrhea be the most common of those GI adverse effects. Skin reactions have been reported with Cefdinir as well. There is a low potential for cross-reactivity between penicillin antibiotics and cephalosporin antibiotics, some more than others. I'm not going to dig into the weeds here on this one, but just recognize that there may be a risk there with cross-reactivity with penicillin antibiotics, even though that risk is fairly low in general. One thing I did want to mention about administration, it is recommended to give 2 hours before or after antacid type medications, so calcium carbonate, for example, as well as iron preparations, okay? And this is basically because that co-administration will block the absorption of Cefdinir, and if we block the absorption of Cefdinir, we're not going to get adequate concentrations to the site of action and treat the infection that we're trying to treat. So definitely co-administration with antacids or iron can increase the risk for treatment failure. All right, well, that's going to wrap up the podcast for today. Do us a huge favor, share us with friends, colleagues, shoot out an email to anyone who may be preparing or needing more pharmacology education. I greatly appreciate it. To those of you who have done that, leave us a rating review on iTunes or wherever you're listening. I greatly appreciate that. It's helped us grow the audience, and I'm really, really thankful for all the support that we've had with this podcast over the, I believe, 6 years now that we've been doing it. So greatly, greatly appreciate that. Very humbled by well over 4 million downloads now at this point. If you're listening to this podcast and looking to sponsor, reach a good healthcare audience, we're always looking for sponsors as well. You can track me down at mededucation101@gmail.com. If you've got comments, feedback on the podcast as well, always open to listening, trying to improve and be better to help you guys learn pharmacology better. So don't hesitate to shoot me an email there at mededucation101@gmail.com. You can also connect with me, Eric Christensen, PharmD, BCPS, BCGP on LinkedIn. And as always, I greatly appreciate the support at meded101.com/store. All your purchases there go directly to help support this podcast and for me to be able to keep it going. So greatly appreciate that. With that said, hopefully you picked up a few practice pearls today, and I hope you have a great rest of your day.